Hi friends, welcome to Pain Policy Practice. Today we'll talk about risks and benefits of opioid therapy in plain and simple language. Long-term opioid therapy usually refers to taking opioid medications for more than 3 months to manage chronic pain. This might be used for conditions such as chronic back pain, severe arthritis, neuropathic pain, or pain after major injuries, and also in some chronic pain syndromes. For some patients, these medications can improve daily functioning and quality of life. But long-term therapy also requires careful monitoring and medical supervision. For some patients, they provide meaningful relief, while for others, they come with significant risks. So today we're going to talk about what opioids actually do, and when they might help, and what the risks are, and also how clinicians think about long-term opioid therapy. Friends, this is not a pro-opioid or anti-opioid discussion. This is about informed, balanced decision-making. So what actually are opioids? Opioids are medications that bind to receptors in the brain and spinal cord. They reduce how pain signals are processed, and they can create a sense of relief or calm. Some of the common examples include oxycodone, hydrocodone, morphine, and fentanyl. And they are very effective for acute pain. They are acute for post-surgical pain, and they're very good for cancer-related pain. But in chronic pain, it's a little different, and that difference matters. Chronic pain versus acute pain. Chronic pain is not simply long-lasting pain. It often involves changes in how the nervous system processes pain. There's central sensitization, emotional and cognitive influences, sleep disruption, and fatigue. So because of this, opioids may reduce pain intensity in some patients, but they may not address the underlying mechanisms. Chronic pain is a system-level condition, and it's not just a signal problem, and that makes treatment more complex. So what are the potential benefits of opioid therapy? Now let's start with the most important benefits, and because they're real. For carefully selected patients, opioids actually may improve pain control. They improve function. They improve quality of life. They provide stability. And some patients can also walk more better, and they can sleep better. They're able to engage in daily activities. And for patients already stable on therapy, sudden discontinuation can cause harm, including withdrawal, worsening pain, and loss of function. In some cases, opioids also serve as a bridge while other treatments are being optimized. So the key point here is opioids are not inherently good or bad, but they are tools, and their value depends on how they are used in medical practice. Now, the other side, the risks. What are the risks of opioid therapy? There's tolerance, which is over time, the same dose of opioid may become less effective. There's physical dependence, where the body adapts and stops suddenly, leading to withdrawal. And this is expected, but it's not the same as addiction. There is opioid use disorder. It's a smaller but serious risk. It includes loss of control and continued use despite harm. Some of the other side effects are common ones are constipation, sedation, nausea, respiratory depression, overdose. There's a condition called opioid-induced hyperalgesia. And in some patients, opioids may actually increase pain sensitivity. Functional trade-offs. Pain may improve, but energy, focus, or clarity may decline. Patients may also experience urine testing, prescription monitoring, strict refill policies, and clinicians must follow DEA regulations, state laws, clinical guidelines, which affects both the patient experience and clinical decisions. So tolerance and dependence. Why is it very important to know about these two concepts? Because over time, the same dose may become less effective, and this is called tolerance. The body essentially adjusts to the medication. So what once worked well may not provide the same relief of pain. And this can sometimes lead to frequent dose increases. But remember, higher doses don't always mean better outcomes. And at the same time, the body can develop physical dependence. So that means if the medication is stopped, suddenly the withdrawal symptoms can occur. So it's therefore important to understand this is expected physiology. Dependence is not the same as addiction. And remember, guys, this dependence is not the same as addiction. Now, addiction versus medical use. Now, there's a smaller percentage, there's a smaller risk associated with opioid use, and that is addiction. But it's an important risk, and that comes under opioid use disorder. No, addiction is different from medical use. In medical use, treatment is structured, monitored, and focused on function and safety. In addiction, there is loss of control, there's frequent cravings, and continued use despite harm. Most patients who use opioids as prescribed to not develop addiction, but because the consequences can be serious. Now, this risk is always carefully considered. Now, this is why monitoring and communication are extremely important. So what are the side effects of opioid therapy? We've already discussed a few of those in a little earlier. Opioids can cause a range of side effects, and some of the more common and noticeable are constipation, which is this single most important side effect. Sedation is another side effect, nausea, and sometimes even vomiting. Now, others are less visible, such as hormonal changes or effects on breathing, like breathing suppression in particular. It's one of the most serious risks associated with opioid therapy, especially at higher doses or when combined with other medications. The key point is this: some risks are obvious, but others can develop quietly over time. Now, I had mentioned about opioid-induced hyperalgesia. Now, in some patients, opioids have the paradoxical effect. Instead of reducing pain, they may actually increase the sensitivity to pain. Now, this phenomenon is a unique phenomenon, and it's known as opioid-induced hyperalgesia. Now, this can be very confusing because pain may worsen even as doses increase. So, more medication does not always mean more relief. Remember that that's a very, very important statement. And recognizing this pattern is critical in long-term care of pain management. Opioid prescribing is one of the most regulated areas in medicine. Clinicians must follow multiple layers of oversight, including federal regulations, state laws, guidelines, and monitoring requirements. Now, this can help prescription monitoring programs, urine drug testing, documentation standards, and structured follow-ups. So it's often driven by the system and not a lack of trust. Understanding this helps reduce frustration and improves collaboration between patients and clinicians. So why does pain care feel structured? Opioid prescribing is one of the most regulated areas in medicine, and that's what I said earlier. Clinicians must balance patient safety, legal requirements, risk mitigation. So when care feels structured, cautious, protocol-driven, it is often system-driven, and it's not personal. Understanding this reduces frustration on both sides. So who may be a candidate for chronic opioid therapy? Pain is severe and it's persistent. Other treatments have been insufficient. Function improves with therapy. Risks are manageable. And importantly, there is a shared decision making. The focus is not just playing scores, but function, safety, and quality of life. Modern pain management is multimodal, and it may include physical therapy, behavioral therapy, non-opioid medications, interventional procedures, lifestyle strategies, opioids. And when used, they're part of the plan and not the entire plan. The goal is lower risk, better outcomes, improved function. Communication. I cannot emphasize that enough between the patient and the doctor, and that is critical. Patients may feel judged, dismissed, restricted, and clinicians may also feel responsible for safety, bound by regulations, concerned about risk. So a better approach is for patients is my goal is to improve function and quality of life. And clinicians should ask the question, let's find the best way to help you and safely get you there. So in closing, long-term opioid therapy is not a simple decision. It exists at the intersection of neuroscience, risk management, public policy, patient experience for some patients, and it also provides meaningful benefit. For others, the risks outweigh the benefits. And the goal is not maximum medication, but it's to maximize function for sustainable care. Long-term opioid therapy is not a simple or one-size-fits-all decision. It sits at the intersection of biology, risk regulation, and patient experience. For some patients, opioids can provide meaningful relief. But for others, the risks, including tolerance, dependence, side effects, and even increased pain sensitivity, may outweigh the benefits. The key is not choosing for or against opioids, but to make individual decisions. And the true goal in chronic pain care is not maximum medication, it's maximum function with some acceptable risk. And there should be shared goals and a balanced understanding of both the benefits and risks. As we wrap up this discussion on the risks and benefits of long-term opioid therapy, the key takeaway is this: making thoughtful, balanced decision-making, which is essential in chronic pain care. But understanding concepts is only the beginning. In our next series, we move into Pillar 2, and that's clinical chronic pain management, where we take a deeper physician-level look at how chronic pain is actually evaluated and treated in real-world practice. And if you're a medical student, advanced practice provider, physician, resident, or fellow listening to this channel, this pillar is especially for you folks. We'll cover how to approach chronic pain workup, including labs, diagnostics, imaging. We'll explore some of the interventional treatments, opioid prescribing guidelines, and how tools like urine drug testing and risk stratification are used to improve safety. And we'll also learn about opioid use disorders and when it's time to escalate care for referral. So this is where clinical reasoning meets patient care. This is Pain Policy Practice, and I look forward to continuing this journey with you. Bye.